There is a moment that frightens almost everyone who experiences it. Dinner is finished. You lean back in the chair, take a deep breath, and suddenly a sharp pain appears behind the breastbone. It may feel like a needle, a hot blade, or a tight knot directly over the heart. You stop moving. You place a hand on the chest. For several seconds, every other thought disappears. Then the pain eases. Perhaps you burp. Perhaps a bitter taste rises into the throat. Perhaps the discomfort returns when you bend forward or lie down. Because the pain is sharp rather than crushing, you may decide it cannot be the heart. You reach for Tums, Pepsid, or a spoonful of baking soda, and wait for the feeling to pass. That conclusion may eventually prove correct, but it is dangerous to make it by sensation alone. A heart attack does not always feel like an elephant sitting on the chest. Cardiac pain can be described as pressure, squeezing, burning, aching, fullness, indigestion, or even a sharp discomfort. It can spread to the arms, jaw, neck, back, shoulders, or upper abdomen. Some people experience nausea, breathlessness, sweating, unusual fatigue, or lightheadedness with only mild chest discomfort. Current American Heart Association guidance is clear. New or unexplained acute chest pain should be evaluated quickly because the first priority is excluding life-threatening causes, even though many patients will ultimately be found to have a non-cardiac explanation. The surprising part is that once dangerous cardiac and vascular causes have been properly excluded, the digestive tract becomes one of the most common places clinicians look next. But the pain usually does not come from the stomach physically touching the heart. It often begins in the esophagus, the muscular tube running directly behind the breastbone and carrying food from the mouth into the stomach. That position creates the confusion. The esophagus, heart, diaphragm, and upper stomach occupy a crowded area and share overlapping nerve pathways. When acid irritates the esophagus or its muscles contract abnormally, the brain may interpret the signal as chest pain. The sensation can feel so convincing that even experienced clinicians cannot safely identify the source from the patient's description alone. This is general education, not a diagnosis. If chest pain is new, severe, unexplained, worsening, triggered by exertion, or accompanied by shortness of breath, sweating, nausea, faintness, weakness, or discomfort spreading to the arm, jaw, back, neck, or stomach, call emergency services. Do not drive yourself, wait for an antacid to work, or assume that a sharp quality makes the pain harmless. There are 3 digestive patterns that commonly hide behind chest pain, and 1 cardiac pattern that must always be respected. The first digestive pattern is acid reflux. The pain or burning often begins behind the lower breastbone after a meal, especially a large or fatty meal. It may rise toward the throat, worsen when lying flat or bending forward, and arrive with belching, nausea, a sour taste, or the sensation of liquid returning into the mouth. This occurs when stomach contents move backward through the lower esophageal sphincter, the muscular valve between the stomach and esophagus. The stomach is built to tolerate acid. The esophagus is not. Repeated exposure can irritate its lining and create the burning sensation commonly called heartburn. Despite the name, heartburn does not originate in the heart. Gastroesophageal reflux disease, or GERD, is diagnosed when reflux becomes persistent, troublesome, or causes complications. Not everyone with GERD experiences classic burning. Some develop chest pain, nausea, difficulty swallowing, painful swallowing, chronic cough, throat clearing, or hoarseness. That variation is one reason reflux can remain hidden behind what appears to be a heart problem. The second pattern is esophageal spasm. Instead of acid irritating the lining, the muscles of the esophagus contract abnormally. The pain may feel sharp, crushing, squeezing, or intensely tight. It can occur while swallowing and may be triggered in some people by extremely hot or cold foods. Food or liquid may feel as though it is moving slowly or becoming stuck. This pain can spread toward the back, neck, jaw, or arms, making it remarkably difficult to distinguish from angina. Medical references specifically warn that esophageal spasm can resemble heart-related chest pain. Diagnosis may require testing such as endoscopy or esophageal manometry, which measures the coordination and strength of muscular contractions. The third digestive pattern comes from pressure beneath the diaphragm. A large meal can stretch the stomach. Gas can increase pressure in the upper abdomen. A hiatal hernia can allow part of the stomach to move upward through the opening in the diaphragm. The resulting discomfort may sit beneath the breastbone, worsen after eating or lying down, and improve after belching or changing position. But improvement after belching does not prove that the heart is safe. A person can experience reflux and coronary disease at the same time. A heart attack may also produce nausea, upper abdominal discomfort, or a feeling mistaken for severe indigestion. The presence of one digestive clue cannot cancel every cardiac warning sign. The cardiac pattern often becomes more suspicious when discomfort is triggered by physical exertion or emotional stress and improves with rest. A person may notice pressure while climbing stairs, walking uphill, carrying groceries, or moving quickly in cold weather. The discomfort may spread and appear with breathlessness, sweating, nausea, or weakness, yet even this pattern is not absolute. Acute coronary syndrome can begin at rest, become unpredictable, or feel different from previous episodes. Women, older adults, and people with diabetes may have less dramatic chest pain and more fatigue, nausea, shortness of breath, back discomfort, or lightheadedness. The word sharp cannot safely rule the heart in or out. I want to tell you about a man I will call Arthur, a representative composite rather than one identifiable patient. Arthur was 67 and had experienced occasional heartburn for years. He knew which foods usually caused it: pepperoni pizza, tomato sauce, fried onions, chocolate, and the large mug of coffee he drank after dinner. His usual reflux felt like heat moving upward from his stomach. He would take 2 Tums tablets, remain upright, and feel better within 20 minutes. Because the pattern was so familiar, Arthur believed he could identify digestive pain immediately. Then one evening, after carrying 2 heavy boxes into the garage, he felt a sharp burning pain in the center of his chest. It reminded him of heartburn, although it began before dinner. He stopped moving, belched once, and thought the discomfort improved slightly. Arthur took an antacid. The pain returned when he walked back toward the house. This time his left shoulder felt heavy, and a layer of sweat appeared across his forehead, even though the garage was cool. He told himself that the shoulder discomfort came from lifting the boxes and that the sweating came from exertion. His wife noticed that his face had become pale. She asked whether he was having chest pain. Arthur answered with the sentence that delays emergency care in thousands of homes: "It's just my stomach." His wife called emergency services anyway. An electrocardiogram and blood testing showed that Arthur was experiencing an acute coronary syndrome. The burning quality, the belching, and his long history of reflux had not protected him from heart disease. They had merely given him a believable alternative explanation at the exact moment when speed mattered. The American Heart Association's chest pain guideline recommends electrocardiography and high-sensitivity cardiac troponin testing as central tools for identifying or excluding heart injury. The diagnosis is not made from whether pain feels sharp, burning, heavy, or digestive. It is made by combining symptoms, risk, examination, electrical findings, biomarkers, and, when appropriate, imaging or additional testing. Arthur received treatment quickly and recovered. But several months later, another episode occurred after a large late-night meal. This time, the discomfort began when he lay flat, rose toward his throat, and arrived with sour regurgitation. Because of his cardiac history, he did not diagnose himself. He contacted his medical team and was evaluated. The heart was not responsible for that episode. The pattern was consistent with reflux. Arthur had now experienced 2 pains in almost the same location from 2 completely different systems. One required emergency cardiac treatment. The other required management of GERD. The sensation alone had not been reliable enough to separate them. His clinicians helped him identify the digestive pattern without teaching him to ignore future cardiac symptoms. He began eating smaller evening meals, stopped lying down immediately after dinner, and raised the head of his bed. His medication list was reviewed, and a clinician-directed trial of acid-suppressing treatment was used when appropriate. Over-the-counter medicines such as calcium carbonate, sold as Tums, may neutralize acid for occasional symptoms. Famotidine, sold as Pepcid, reduces acid production through a different mechanism. Proton pump inhibitors such as omeprazole, sold as Prilosec, suppress acid more strongly and are commonly used in GERD treatment. But none of these products is a home diagnostic test for the heart. If chest pain improves after an antacid, that may support a digestive explanation, but it cannot reliably exclude a heart attack. Symptoms can fluctuate naturally while the medication is taking credit. The heart and digestive tract can also produce symptoms simultaneously. New chest pain should never be used as an opportunity to experiment with one medicine after another while delaying emergency assessment. Arthur's later evaluation also revealed something important. Reflux was not caused only by too much acid. The lower esophageal sphincter was allowing stomach contents to move upward when it should have remained closed. Large meals increased stomach volume. Lying flat removed gravity's help. Excess body weight and smoking can increase reflux risk, and certain medications can worsen symptoms in some people. Before I continue, let me ask you something important. Have you ever made a major decision while feeling worried, rushed, or unsure which information you could trust? That is how costly mistakes often begin. A frightening headline can influence your investments. Conflicting health advice can leave you confused. A convincing salesperson, online scam, or emotional family situation can pressure you into acting before you have checked the facts, and after 50, the consequences can be much greater. One poor decision may affect your retirement savings, your health, your independence, or your peace of mind for years. That is why I want you to take a look at the decision trap. It is a practical guide designed to help adults over 50 recognize fear, manipulation, hidden bias, misleading information, and high-pressure tactics before making an important decision. Inside, you will find a simple step-by-step system for slowing the situation down, checking the evidence, asking the right questions, comparing your options, and protecting yourself from mistakes that could become expensive. Do not wait until a bad decision teaches you the lesson the hard way. Click the link in the description and get your copy of the Decision Trap now. Then come straight back, because next I will give you 4 specific details that can help a doctor separate digestive pain from a possible cardiac emergency without ever delaying urgent care. There are 4 details worth recording when chest discomfort occurs, but recording them should never delay emergency care. The first is the trigger. Did the discomfort begin during walking, climbing, lifting, or emotional stress? Did it begin after a meal, when bending forward, or after lying down? Did swallowing hot or cold liquid trigger it? Did it appear without any predictable trigger while you were resting? A meal-related pattern may point toward reflux. A swallowing-related pattern may suggest the esophagus. An exertional pattern raises concern for the heart. None of these clues is strong enough to make the diagnosis alone. The second detail is the full sensation. Do not report only sharp pain. Describe whether there is burning, pressure, squeezing, heaviness, stabbing, fullness, or the feeling that food is stuck. Explain whether the discomfort rises toward the throat, spreads to another area, or remains in one small spot. Cardiac pain can occur in the chest, shoulders, arms, neck, jaw, back, or upper abdomen. Breathlessness and fatigue can also function as cardiac warning equivalents even when chest discomfort is not dramatic. The third detail is duration and repetition. A sensation lasting 1 second is different from discomfort that continues for several minutes, disappears, and returns. Reflux may persist or fluctuate after a meal. Esophageal spasms can produce intense episodes. Heart-related discomfort may also come and go. Do not allow a disappearing pain to create false reassurance. Heart attack symptoms can ease and return, and unstable angina may be unpredictable or occur at rest. The fourth detail is everything occurring beside the pain. Sour taste, regurgitation, belching, painful swallowing, and symptoms worsening while lying down support a digestive investigation. Sweating, shortness of breath, nausea, faintness, unusual weakness, or pain spreading toward the arms, back, neck, jaw, or stomach increase concern for a cardiac emergency. Difficulty swallowing, persistent vomiting, vomiting blood, black tarry stool, loss of appetite, or unexplained weight loss also requires medical assessment because these can indicate complications or another serious digestive disorder. The useful sentence in a non-emergency appointment is not, "My stomach gives me chest pain." It is more specific. The discomfort begins about 30 minutes after eating, becomes worse when I lie flat, rises toward my throat, and occurs with sour regurgitation. My heart has been appropriately evaluated, but could GERD or an esophageal disorder be contributing? That description gives the clinician a reproducible pattern. Depending on the history, evaluation may involve a medication trial, upper endoscopy, reflux monitoring, testing of esophageal movement, or investigation of other digestive causes. But those tests usually come after the immediate threat of heart disease has been considered according to the person's symptoms and risk. Risk matters greatly after 60. High blood pressure, diabetes, high LDL cholesterol, smoking, kidney disease, known artery disease, and a family history of early cardiovascular disease all change how urgently chest symptoms are interpreted. A person with several cardiac risks should be especially cautious about assigning pain to yesterday's meal. The most dangerous misconception is that heart pain must be dull while stomach pain must be sharp. Human nerves do not follow that rule. Reflux can burn, squeeze, or stab. Esophageal spasm can imitate angina. A heart attack can resemble indigestion. Even experienced professionals use structured evaluation because descriptive words overlap too much to provide certainty. The title says that the pain is not the heart, but the stomach. Sometimes that is exactly what the final diagnosis reveals. The esophagus may be inflamed. Acid may be rising after meals. Muscles may be contracting abnormally. Pressure beneath the diaphragm may be referring discomfort into the chest. But the cardiologist's real warning comes before that conclusion. The stomach is allowed to become the explanation only after dangerous causes have been taken seriously. It should never become the excuse that prevents someone from calling for help. Arthur survived because his wife did not accept the familiar story his symptoms seemed to tell. Months later, he learned that digestive pain could feel nearly identical. The lesson was not to fear every burp or burning sensation. It was to stop asking whether the pain felt sharp enough to be harmless. Your chest contains structures separated by inches but connected through overlapping nerves. When one of them sends a distress signal, the brain may not identify the sender correctly. The pain may come from acid. It may come from an esophageal spasm. It may come from the heart. And until the dangerous possibility has been excluded, the location and sharpness of the pain cannot safely make that decision for you. Before you leave, understand what is really at risk. The cost of this guide is small, but the cost of one rushed financial decision, one misleading health claim, one convincing scam, or one panic-driven reaction can be far greater. It can cost you money you spent years saving. It can cost you confidence in your own judgment, and in some cases, it can cost you your independence and peace of mind. The decision trap was created to help you recognize pressure, fear, hidden bias, and misleading information before they influence an important decision. You may not need this guide every day, but on the day you face a decision that could affect your savings, health, or future, not having a clear system may become far more expensive than getting one today. Click the link in the description and get your copy of The Decision Trap now, because the best time to protect yourself from a costly mistake is before you make it.